afternoon. This is David Wallace, PV reporter, reporting from ASH 2016 in San Diego. And with us today, I have Dr. Jacques Kiladjian. And Dr. Kiladjian is going to talk to us today about outcomes of patients after discontinuation with the interferon in MPN patients. So, first of all, if you could just give us a little bit of your background, that would be helpful for our readers.
Okay, good afternoon, David.
Sure.
So I'm a hematologist working in Paris in Saint-Louis Hospital, and I'm at the head of a unit taking care of patients included in clinical studies, mainly kind of platform for these patients. And my personal outpatient clinic is more focused on patients with myeloproliferative neoplasms, and almost 90-95% of the patients I follow in my outpatient clinic have an MPN. So for several years I'm really interested in these diseases.
Okay, all right, very good. What were some of the benefits that you found with patients on interferon, and then what were some of the outcomes that you found after discontinuation with interferon?
In fact, we had the idea to look at these patients after discontinuation because one of the potential advantage of interferon compared to other therapies like hydroxycarbamide, for example, is that it has been reported that in some patients you may stop treatment without reoccurrence of the disease and without relapse, with blood counts that remain normal for a while. So we said, okay, we have a large center. We identified 333 patients with MPN who received interferon at any time during their disease in our center. And among them, 149, almost 150 patients had discontinued the drug. So we decided to look what was the reason for discontinuation and what happened to these patients after discontinuation.
Okay.
In fact, we found that although half of patients discontinued because of toxicity, some toxicity reason, we still had about 35% of those patients who discontinued therapy because they were very well, with normal counts, with usually low dose of interferon, because although there was no particular guideline in my institution on how to manage interferon therapy, all the doctors had the same attitude. After a while on drug, after 1-2 years on treatment, they were started to decrease the dose, to little by some increment, decrease the dose,
right,
taper the dose, and then stop if nothing happened, if the counts were still normal. And interestingly, we found that a proportion of these patients, about 20-25%, remained off any therapy with normal counts for a median time when we did the analysis that was about 3 years, with the maximum being 11 years for one of my patients who had discontinued and has normal counts. And we found that what was important in terms of remaining off therapy when we did the statistical analysis was that the median dose was important, the cumulative dose of interferon that was received, and also the deepness of molecular response, meaning that we followed the JAK2 mutation, and those patients who remained off therapy for a long time had a very low JAK2 mutation at time of discontinuation.
Okay.
So this is the first step, but we had also other analyses in these patients, especially looking at important events for MPN patients that are thrombosis, evolution of the disease to more aggressive disease like myelofibrosis or acute leukemia, and of course death. And we analyzed what we call the event-free survival, meaning patients having a normal life without transformation, without thrombosis. And again, what we could show and what we found with this statistical analysis, that two parameters were independently associated with a longer event-free survival. The first one was starting early interferon after the diagnosis. So the earlier you start, better the outcome after that. And the second, again, just like for the previous endpoint, was the deepness of molecular response. The lower you reduce the JAK2 mutant allele burden on therapy, the longer this event-free survival. So for the first time, we could show some benefit of reducing the allele burden, because often people say, okay, you reduce JAK2 and so what?
Right.
Is it important for patients' life? So here we have the first evidence, so it's a retrospective study, but we have the first evidence that reducing JAK2 to very low level, meaning in our cohort of patients it's less than 10 or even better less than 5% at time of discontinuation, correlates with better outcome.
Okay, all right. Good. Now, I noticed in the abstract there was a statement in there that there seems to be some dispute about the clinical relevance of achieving the molecular response. I wonder if you could shed some light on that for us.
Yeah, I think we have the experience in other diseases. In hematology, for example, patients with chronic myeloid leukemia, we know very well now for many years that you have to reduce the BCR-able protein to achieve good responses and good survival without transformation. Mm-hmm. So it seems logical in every diseases where you have a kind of marker of the tumor cells.
Right.
Reducing this marker logically should induce better outcome for the patient, but there was no clear evidence for that. So with this study we found this first evidence, and what we want to do now in France at least is to have a validation of this on a larger cohort. This was only done in my hospital, in Saint-Louis Hospital. Now we will do the same study in the whole country to collect the patients who stopped interferon, to see if we can confirm that this molecular response really means something for the patient. It means less treatment, possibility of discontinuation and normal counts, and less thrombotic event, less transformation to acute leukemia.
Okay, and I think you've probably answered a couple of my next questions, but
I apologize.
No, that's good. That means we're right on target. So what were the best responses that you saw and the reasons for discontinuation? I think you kind of told us that, complete hematological remission, that's the best response.
Yes.
And then reasons for discontinuation.
Well, we had half of patients discontinued for toxicity, so it's still a concern, knowing that there was no particular interferon proposed, because this was the routine practice, what we can use in France.
Right.
So most of them had PEG Interferon-Alpha 2A, Pegasus,
right.
But also some of them had pegylated 2B or even non-pegylated interferon. So it was a mixture of several types of formulations of interferon, so the tolerance may be different from one to the other.
Okay.
But there was no particular major reason for discontinuation. I think about 1/3 of discontinuation was due to autoimmune phenomena. Like, for example, you know that interferon is a kind of immunostimulant.
Right.
And probably that's why it works so well and helps people to eliminate themselves with their own immune cells, the bad cells from the MPN. But the bad side of the coin is that sometimes it goes too far and so attacks the thyroid, for example, or other organs. So one of the main reasons for discontinuation was the occurrence, for example, of autoantibody. We regularly check when we treat the patients with interferon at least every 6 months or sometimes even more frequently for the occurrence of such autoantibodies to prevent the development of a kind of autoimmune disorder. So many of these patients discontinued because we saw the appearance of this autoantibody, and before something happens, the investigators, the doctors preferred to stop interferon. So this was a quite relatively important proportion of discontinuation. So just a biological parameter, but before a real disease occurs, we prefer to stop.
Okay, and that brings to mind a question I am a PV patient myself, as most folks know, and I also have been on Pegasus. What are some of the autoimmune diseases that you look for? And then what are the markers, or how are they discovered? I mean, is that going to come out on a blood test, or tell me more about that?
Yes, it's on the blood test. You can check for an array of so-called autoantibodies. The most, let's say the less specific, but the most frequent are what we call the anti-nuclear antibodies.
Okay.
That's the one that we find in lupus disorder, for example. That is the most famous of autoimmune diseases. So these are the one we usually detect first. But also thyroid autoantibodies against thyroid are the most frequent. But this is a well-known toxicity of interferon. That often the endocrinologists say you don't have to discontinue necessarily the drug for that, because if it's an hypothyroidism, then you can give some thyroid hormone. It's not good because you induce another need of the therapy, but it's not always a reason for discontinuation. But it has to be discussed with the patients, sometimes internists that know well these induced disorders.
Sure.
And sometimes we can monitor these antibodies without discontinuing the drug in collaboration with other specialists. But other times it's sometimes preferable to stop before we induce a real disease.
Okay. I think I read in the abstract that 73% of the patients were alive in complete hematological remission for a median of 42 months after interferon was discontinued. Is that correct?
Yes, it's correct.
Okay.
But some of them, in fact, that's also another point, because this was purely observational. We collected what the doctors did for their patients. There was no guideline, no rules. And in several patients, for example, when this autoantibody occurred, the doctor preferred to stop interferon and immediately switch to Hydrea, for example. So we don't know what would have happened to these particular patients if they didn't start another therapy. So maybe more patients could be free of treatment, but because the doctors were not aware of this possible good effect on the long term of interferon, they switched directly to another cytoreductive drug. So we don't know. So the proportion of So I think my advice now for people who use interferon, if someday you have to discontinue for any reason, because you're well, because what we do usually is to taper the dose over 1 year. Every 3 or 6 months we reduce by 50%.
Sure.
And then at a certain point we do one injection every 2 weeks instead of every week, for example, etc. And if the blood counts are normal, we stop. So if you stop interferon, maybe just carefully look the blood counts, because some of my patients were reluctant to stop. They're saying, I'm very well on interferon, why should I stop? I said, let's try. What is the problem? Do we just monitor your counts frequently, and if something happens, we restart or we propose another treatment. And so with that, you can see some patients, and the first one I stopped, it was now 11 years ago. And she's very well without any drug, with normal counts. Sometimes the blood counts re-increase after 6 to 12 months. Then, in some patients, we restarted interferon successfully. So it's not a big concern. But you may have this try of stopping and see what happens if the patients are well, of course.
Okay, so really it's kind of a balancing act. I mean, so there's no stop off at 3 years or 4 years. You kind of have to look at the counts, perhaps see how the patient feels, and then make a decision jointly. And
maybe the allele burden is important in that perspective, because what we found is that if the allele burden is still above 15-20%, then the chance to remain off therapy is very low, around 20% only. If you go down to less than 10%, then you increase to almost 40-50% chance of remaining off therapy. If you are less than 5%, then the chance is more than 60%. So that maybe this may also help, and maybe not stop the drug if your allele burden is still above 20%, for example, because there the chance of remaining off therapy is smaller.
Okay. So I guess this brings to sort of a question for me is, what are your next steps after this study? Where are you going to carry it next?
Well, we want to try to start a study of interferon discontinuation. And so if with this larger cohort I mentioned, if we can confirm these findings, we will define some rules for stopping interferon, saying, for example, what seems to be now with our first results, but this has to be confirmed, but one possible design could be that patients will receive at least 2 years of treatment, and with an allele burden reduced down to less than 5%, we could propose discontinuation and just observation and see how many patients remain off therapy, etc. So this will be the next step, a prospective study to validate this duration and the molecular response.
Okay. That actually brings to mind a couple sort of final points. With the introduction of the new ROPEG interferon, I believe it's P1101, are you guys involved in your institution with that form of interferon at all at this point?
Yes, we have participated in the PROUD PV study, so we have treated several patients already with ROPEG interferon, which is a very nice formulation of interferon, administration every 2 weeks only, and sometimes even one injection per month is sufficient in some patients. The tolerance is quite good, so it's close to what we know with Pegasus, for example, but slightly even better tolerated. So, and most importantly, since the PROUD PV results were presented during this meeting, we hope now that this drug will be approved for the first time. We will have an approved interferon for MPNs, so it will be a major improvement, I think, for everybody, for the doctors, and of course for the patients in terms of safety, reimbursement, etc. So I hope that with this new formulation, more patients will have access to this therapy. It's not for everybody, clearly. I'm not saying that everybody should receive interferon, but at least, I mean, with a safe form that is manageable in terms of tolerance, we could use it in more patients and maybe have more of these long-term good results and discontinuations.
Okay, all right. Well, I'm going to throw you a little curveball. In our country, we tend to discuss MPNs as being a rare disease, and the numbers go anywhere from reports as low as 1 in 100,000 to a recent study that Dr. Mesa did, his landmark study, that varied anywhere from 43 to 56 patients out of 100,000. So can you give me a little background in your institution or in France as a whole? What kind of numbers are you seeing per 100,000? And do you really consider it a rare disease?
Well, it's in the same margin you mentioned. So we consider, for example, in France, where we are, I think, 65 million inhabitants or 70 million inhabitants, that there are probably around 500 new patients with myelofibrosis every year. Probably the double for PV, around 1,000, and 1,000 or 2,000 ET patients. So altogether, it remains a rare disease in terms of incidence, new cases occurring every year. But hopefully, our patients live very long.
Yes.
And they have almost now a normal life expectancy, especially for ET patients, for example. So then they accumulate, let's say, and the prevalence, what we call the prevalence, the number of patients at one time point that are here is very high. For example, in my hospital, we follow more than 2,000 patients with MPN as an active cohort of patients. So it's just one single hospital. Still, we are specialized in MPN, well known, but we have this cohort of more than 2,000 patients. So the patients are there. Not too many every year new patients, but a lot of patients living well, more or less, and as well as possible. But
in a full lifetime. Okay, so that's certainly positive. And one final question: how does ruxolitinib kind of work into the mix? You know, you have doctors, some of them are frontline with hydroxyurea, some of them start with interferon right away, and then we have ruxolitinib. How do you determine what is a better agent, or when does ruxolitinib come into the mix?
For the time being, I think ruxolitinib has a very good role as a second-line therapy. After hydrea, clearly, because this was the trial, probably also after interferon. For example, sometimes if you start interferon as a first therapy in a patient, it's because often the patient is quite young, and you have this concern of long-term use of hydrea that may harm,
Right.
and may not be so good to accumulate years and years of hydrea.
Right.
So then if this patient fails or doesn't tolerate interferon, it would be more logical to go to ruxolitinib that is non-lacrimogenic, clearly. So I think it has a place as second-line therapy, clearly, but also maybe for some patients with a high symptom burden in PV, especially pruritus. That some patients, it's few patients, but in my experience, in some of my PV patients, it's a major problem. Nothing works. They tried everything. They cannot even take a shower. They abandon that. So, and the drug, ruxolitinib, is very, very efficient for this symptom. So this particular small population of patients with this very terrible symptom that really makes a very poor quality of life, then it's, of course, the best treatment, I guess, for these patients.
Okay. Well, in wrapping up, let me ask you, what have been the highlights from ASH this year that you've seen, and what are our rays of hopes as patients and physicians?
Well, in MPNs, I think for me it was the news about interferon because of the PROUD PV result, and also the MPD consortium study that compared hydrea to Pegasus as a first-line therapy in PV, but also in ET patients. Preliminary results were presented by Dr. Mascarenhas during the meeting here that are quite balanced with no advantage clearly for interferon, but it's only 35 patients in each arm, and we have to wait for longer follow-up and inclusion of all patients. That will be about 170 patients, if I remember well, in total.
Okay.
So we will have probably next year the update of these trials. So then we will better define, maybe with the results of PROUD PV and the results of the American NPDRC study, what is the exact role of hydrea versus interferon in first-line therapy for our patients. This will be helpful, I think, to better discriminate which patients has better advantage to take this or that drug.
Okay. All right. Well, and hopefully in coming years we'll have new therapies to kind of toss into the mix and hopefully cure MPNs one day. But I certainly do appreciate you spending the time to discuss your study with us, and I'm going to keep my eyes open and stay on top of your latest research. Thank you so much.
Thank you.
Appreciate it.